When the doctor uttered the words lung cancer, time stopped. Am I going to die? Will I get to raise my children? What will they miss out on? This was the gut-wrenching fear of lung cancer survivor Ashley Stringer. It was intangible, raw, made sharper with each breath. And yet, against the gravity of that moment, others whisper, "Every breath is a gift, and I won't waste a single one." Lung cancer isn't just a medical diagnosis, it's a sudden collision between life's fragility and its urgency. Lung cancer, a comprehensive overview. What is lung cancer? Lung cancer begins when abnormal cells grow uncontrollably in lung tissue, most commonly in the lining of air passages, potentially invading nearby structures or spreading, metastasizing to distant organs. It's the leading cause of cancer-related deaths worldwide and accounts for humankind's highest mortality percentage per year from a single cancer type. Resistance to treatment and late diagnosis contribute heavily to poor outcomes. There are two main types: non-small cell lung cancer, NSCLC, approximately 85% of cases. Include subtypes such as adenocarcinoma, often diagnosed in non-smokers, squamous cell carcinoma, and large cell carcinoma, small cell lung cancer, SCLC, approximately 15% of cases, and usually linked to smoking. Highly aggressive, it spreads quickly and has lower survival rates. Who is most at risk? Risk factors: major factor relative risk, notes tobacco, smoking cigarettes, pipes, BD, etc. Up to 30 higher risk versus non-smokers, main cause in 80 to 90% of patients. Secondhand smoke, moderately elevated risk, 20 to 50% of non-smokers diagnosed with LC have this exposure. Radon gas, asbestos, heavy metals, diesel fumes. Silica, moderate to high. Based on intensity, these agents cause DNA damage and lung scarring. Air pollution and biomass smoke, growing risk factor especially in South Asia and industrial centers. Genetics, for example, EGFR ALK mutations 1.5 to 7 times in familial cases, more frequent in women, East Asians, and non-smokers. Age and comorbid lung disease increases after age 60. COPD, emphysema, our additive combined risk is exponential. Even non-smokers can develop lung cancer. Due to these non-tobacco risks, studies show 10 to 30% of new diagnoses occur in never smokers. Show lung cancer manifest signs and symptoms. Symptoms often mimic routine respiratory illnesses and usually appear late. Persistent cough or change in chronic cough. Most common initial sign: hemoptysis, coughing up blood or rust-colored phlegm, chest pain that worsens with breathing or coughing, shortness of breath, wheezing, hoarseness, weight loss, fatigue, muscle weakness, recurrent pneumonia or chest infections, unexplained finger or toenail clubbing, bulbous, rounded nail beds, an early but rare sign seen in approximately 5 to 15% of cases. Advanced disease may present with musculoskeletal pain from bone metastases, neurological symptoms, headaches, dizziness, memory changes, brain spreads, welling of face, neck, superior vena cava syndrome, abnormal liver function, or jaundice. Diagnosis and staging essentials. Early detection is rare. Most patients are diagnosed at stage 3 or 4, reducing surgical options and survival prospects. Diagnostic tools include imaging. Chest X-ray gives low-dose CT/LD-CT. For high-risk adults aged 5574P, TCT quantifies tissue uptake and staging. Biopsy methods: bronchoscopy, CT-guided core needle sampling, endobronchial ultrasound. Molecular tests identify targetable mutations, for example, EGFR, K, ROS1 for personalized treatments. Staging system, TNM, stage II, confined to lungs. Surgery may be curative. Stage 3, involvement of adjacent structures or lymph. NODs requires multimodal therapies. 4. Metastasis beyond lungs. Treatment is palliative treatment. Options treatment depends on cancer type NSCLC versus SCLC stage. At presentation molecular markers, for example, EGFR, ALK, PD-L1 patients' general health for NSCLC early stages. Surgery, lobectomy, segmentectomy, pneumonectomy udunan chemotherapy, post-surgery to reduce relapse risk radiotherapy, or SBRT, for patients on whom surgery is not safe for advanced metastatic NSCLC, targeted therapies. For example, EGFR-TK is a ALK inhibitors, immune checkpoint inhibitors with or without chemopalliative, radiation for metastasis-related pain or obstruction for SCLC. Chemoradiation is standard for limited stage. Disease chemotherapy alone for extensive stage disease prophylactic. Cranial irradiation PCI to prevent brain metastasis immunotherapy is increasingly used along with chemoclinical trials, remain a vital option for advanced or resistant cases prognosis. And survival outlook comes very widely by staging and treatment. Response: localized NSCLC stage 1 has a 5-year survival rate of approximately 60%, regional stage 2-3 NSCLC, approximately 33%. Distant metastasis stage 4, approximately 7% overall less CLC, approximately 22-27% 5-year. Survival for limited stage, 5% for extensive stage males, non-smokers, and individuals with EGFR ALK mutations often fare better. Newer targeted and immunotherapies are steadily improving long-term outcomes. 7. Complications and quality of life issues. Patients may face pleural effusion fluid around lungs, causing breathlessness, hemorrhage in airways, compression symptoms, superior vena cava syndrome, nerve palsy, cachoxia, extreme muscle wasting and fatigue, emotional and psychosocial stress, depression, fear of death, treatment, side effects, nausea, neuropathy. Pneumonitis from radiation, palliative and supportive care plays a crucial role in managing symptoms and maintaining dignity. Prevention and screening. Strategist primary prevention. Hubakitil tobacco use, active and passive. Public smoking bans reduce incidence by 40 to 50%. Implement air quality controls, radon, outdoor pollutants, biomass smoke. Regulate workplace exposures, asbestos, diesel, heavy metals. Encourage healthy diet, regular physical activity, and weight control. Secondary prevention, screening, annual low-dose CT scans recommended for hires. Individuals aged 55 to 74 with is greater than or equal to 30 pack-year smoking history. Early detection via screenings can improve 5-year survival by up to 50%. When to see a doctor. Persistent cough greater than 3 weeks. Unexplained weight loss in sputum, shortness of breath or chest pain. Early referral for imaging and evaluation is critical. Can light smokers or non-smokers get lung cancer? Yes. 10 to 30% of cases occur in non-smokers due to factors like radon, genetics, air pollution. Is lung cancer always fatal? No, it is treatable, especially at early stages. Even advanced cases now benefit from targeted treatments and longer survival. Question and circin: light smokers or non-smokers get lung cancer? Yes. 10 to 30% of cases occur in non-smokers due to factors like radon, genetics, air pollution. Is lung cancer always fatal? No, it is treatable, especially at early stages. Even advanced cases now benefit from targeted treatments and longer survival. What about vaping or safer tobacco products? These are not safe. They increase cancer risk similarly to traditional smoking. What if I have a genetic mutation? Tests for EGFR, ALK, ROS1, etc. can guide precision treatments with better outcomes. Can healthy living really help if diagnosed? Yes. Nutrition, physical activity, quitting smoking, and halting carcinogen exposure help patients tolerate treatment and improve overall survival. Final takeaway: lung cancer remains a formidable global challenge due due to its silent early course and often late detection. Still, primary prevention, especially complete tobacco control and clean air, prevents the vast majority of cases. Early detection, for example LDCT, in high-risk groups dramatically improves outcomes. Advanced therapies targeted. Drugs and immunotherapies allow better survival rates, even for late-stage cancer. Like, comment, and subscribe to our channel for more health-related content. Thank you. And take care of your health. Subscribe now and turn your health journey into a lifestyle.